you just showed the two pictures about IVUS and OCT, and maybe you can give some information about what do you think, when should we use IVUS, when do you use OCT in your cath lab, what are advantages and disadvantages of each, I would say, very good imaging modalities that we have available now in our cath labs?
Yeah, so that's obviously the ever-returning, actually quite difficult question, you know? I mean, there is two imaging technologies that we have at our disposal in routine practice, one based on ultrasound, one based on infrared light. And both, you know, have their pros and cons. So typically, people would say, well, the resolution is different. IVUS has a resolution of about 20 to 40 microns, whereas OCT is more in the range of 10 to 20 microns, which results in the fact that the near-field resolution of OCT, so for instance, if you want to interpret stent deposition, if you want to interpret very small erosions or intimal tears, OCT is the technology that's perhaps somewhat easier to interpret. But conversely, in routine practice, there are, I think, in my opinion, two things that are of critical importance when looking at the intravascular image. One is the ability to see landing zones and plaque characteristics. Well, with that, I think both technologies are suitable. With that difference that with IVUS, the penetration depth is deeper. So you typically see the whole vessel. In this OCT image on the right, you see a vessel, a nice three-layered appearance somewhere between 3 o'clock and 7 o'clock. But between 7 o'clock and 2 o'clock, you actually no longer see the media, which means that you actually need to do a visual interpretation of where you think the media should be. Now, with new AI algorithms, that is being facilitated for the investigator or for the operator, but with the current technology that is available in most cath labs, you really mostly see the lumen. And for those people that are not trained that well in intravascular imaging yet, this may be misleading, because in cases in which the lumen is large, for instance, this is a lumen of 6 square millimeters, the vessel actually may have a reference lumen area of about 12, meaning that there's still a plaque burden of about 50%. And that is critical and is much easier interpretable based on the intravascular ultrasound, in which you actually see the full vessel integrity in each and individual pullback, unless there is a massive amount of calcium. So I think that is a clear distinction between both technologies. But in clinical practice, I would argue that in 80% of the cases, both technologies are feasible from a technical perspective. They will help you to guide PCI as long, and you mentioned it already, if you're not only able to see, but if you're also able to interpret what you see on either IVUS or OCT. Specific indications can be mentioned, for instance, CTO treatment, in which you may go subintimal. You may not want to inject high boluses of contrast, so in those cases, IVUS may be somewhat more easy and at least safer, perhaps, in my perspective. Left main disease, you want to disengage the guide, really get a clear understanding of the ostium of the left main or right. In those cases, again, IVUS perhaps somewhat easier to interpret. Conversely, patients presenting with non-STEMI and perhaps ambiguous or unclear culprit lesions, it's clear that OCT may have an advantage because of its increased near-field resolution. So, in summary, both technologies have pros and cons. Both are widely applicable. In my personal experience, IVUS is perhaps the somewhat more user-friendly and generically applicable technology. Whereas OCT obviously benefits from the higher resolution that may benefit imaging in certain cases. That said, there is one thing I think that is interesting, because in the past we were used to look at IVUS images of about 20 megahertz, whereas now with the novel technologies we actually have high definition IVUS ultrasound at our disposal, which actually gives you images with a resolution of 50 to 70 megahertz, in which the resolution actually increased from about 60 microns to 20 to 40 microns. And this is just an example of the assist system, which allows you with very high resolution to actually appreciate the intima media and adventitia in a single cross section, with a resolution that is definitely not comparable to the initial IVUS images that we were used to look at when we started imaging many decades ago. So with that, I think with the introduction of HD IVUS, both for the assist as well as with other competing technologies, the gap between IVUS and OCT in terms of resolution now got smaller. And I think this is something that can be interpreted as a favorable item for the use of IVUS in routine practice. Before we go to the next session, Christoph, any thoughts from your side on where you think that pros and cons exist between IVUS and OCT? Any particular preference or any specific insights on what you think should be specific cases that may or may not benefit from IVUS?
No, I think it's important just to have for your cath lab, for your specific procedure, I would say maybe just your default strategy. And we have two tools now available which can guide you through, I would say, how you already stated out, 80% of every situation. But I think for your for yourself, it's important to rely on the more practical, I would say, from a more practical point of view, on one of this imaging modality and define this as your default strategy. And maybe it's in some cases then helpful to have the other imaging modality available as well. In my cath lab, I use IVUS as my default strategy because I can use it multiple times in one situation without using more contrast with every run. I can use it like a TTE probe, for example, just to go back to the lesion that I wanted to look after the long pullback and so on. So it makes it a little bit more practical to really understand the anatomy, and this is from my point of view helpful in several in some of the patients.